Sounds. Are you ready? Blue lights on? Okay. Tuesday, May 6th, it is Public Safety Subcommittee. We are ready to legislate. Okay, actually not legislate, but have public hearings. Note for the record that Senator DBS is excused. Oh, look, nobody needs the excuse on our side. That's nice. Okay. Steve, why don't you tell us loudly what it is we're going to be doing today?
Thank you, Mr. Co-Chair, members of the committee. Today before you, we have the Department of Corrections providing invited testimony on House Bill 5004 in three areas: community corrections cost study, the Oregon State Penitentiary replacement, and tied to that, the agency geriatric facilities plan. Thank you, Mr. Co-Chair.
All right. Anything from the group before we open up the public hearing on this? We're going to try to open up a public hearing without looking like a comedy hour. Come forward.
Just to be, it's information.
Informational meeting, which is a public hearing as far as I'm concerned, because the public's listening. Come forward. House Bill 5004. Good luck, gentlemen. Welcome.
Co-Chair Evans, Co-Chair Broadman, for the record, my name is Mike Reese. I'm the Director of the Oregon Department of Corrections. And joining me today will be Assistant Director Jeremiah Stromberg and Assistant Director Thom Martin. Members of the committee, good morning. Thank you. We appreciate the opportunity to come back and present on Phase 2. Phase 1, as you'll recall, was our budget overview and an overview of the Oregon Department of Corrections. We talked about our nearly 4,800 staff members working at 12 facilities across the state of Oregon and the nearly 12,000 adults in our custody and care. I want to give a shout out because this week is National Correctional Employees Week. And so it's a time when we celebrate the dedicated staff that are committed to our mission to promote public safety across the state of Oregon, promote accountability, and transform lives. Today we're going to do a deep dive, as Mr. Robbins said, into three areas. First will be the community corrections cost study, and then the OSP replacement, which I suspect if we are building a new facility will sound much like this for many, many years. And then finally, development of a centralized healthcare facility. And with that, I'm going to turn it over to Assistant Director Jeremiah Stromberg. And I just want to tell you how much I appreciate the work Jeremiah has done in the Department of Corrections and for community corrections across the state of Oregon. He is well regarded and well respected in his profession, person who's dedicated his career to cost-effective and evidence-based practices in community corrections. And I think you'll see that reflected in his testimony today. Thank you.
Welcome.
Thank you, Director. Good morning, Chair Evans, Chair Broadman, members of the committee. For the record, Jeremiah Stromberg, Assistant Director of the Community Corrections Division with the Department of Corrections. And this morning, I'm going to briefly take a deep dive, drill down, if you will, into the Community Corrections budget.
Don't make me use the bullhorn.
To drill down into this budget so that you have a clear understanding of both how the base budget is built, why we do the 6-year cost study, and what has been the history of the previous 3 cost studies that the department has put forward. So reminder, some of these slides may look familiar from my presentation in March, but our budget is built off of 2 primary components. First, we determine a capitated rate. What is the cost per person per day to be supervised on probation, parole, post-prison, or any of our prison leave programs in the community? We then take that rate and we multiply it against the forecast for the upcoming biennium. And so I'll be sharing with you, based on that April forecast you received a few weeks ago, what the new budget is as we move forward through this process. So to develop that capitated rate, we take snapshots throughout the year. We look at how many individuals are high risk, medium, low, how many are in the new category where we're providing intensive assessment and determination of what the next 1 to 3 to 5 years of supervision is going to look like. And we have developed rates over the years for each of those individual buckets of individuals, if you will. We also have the local control rate. This is the number of individuals the sheriffs are housing on behalf of the Department of Corrections. So anyone serving less than a year, sentenced to less than a year, remain within the county jail instead of coming to the Department of Corrections. And they are funded through this capitated rate as well. So it's one check going to the county, and for the county then to determine how much goes into supervising those in the community, as well as funding the appropriate number of jail beds to house the population DOC would otherwise be housing. And so for this upcoming biennium, that rate is sitting at $15.09 per day. And so you can see the cost per day at $358,000 divided across the snapshot of the population we'll be serving, and that's how we determine the $15 rate. That would be simple enough, except statute requires that every 6 years the department shall conduct an actual cost study to determine the amount incurred by the counties to provide for management, support services, supervision, and sanctions for individuals on supervision. This was designed as an opportunity to reset the community corrections budget every 6 years. As we know that supervision changes as any industry does over a period of time, and that this was the best mechanism to be able to inform the legislature and consider a reset to a new capitated rate, a new budget amount for moving forward. So the department has developed this, and we have done this consistently since 2006. There's two components to it. We look at our most recent time study. What is the amount of time we're actually spending working with individuals in the community? And not just parole officers, but this is management, support staff, anyone who is in direct contact with the individuals in the community. And we then take that time and we look at the actual finances occurred during the most recent year. So in this study, it was for 2024, and we look at all the monies that are being appropriated to community corrections to determine then what a new capitated rate could or should be in that process. So a little bit deeper dive. Our last time study was in 2017. We chose not to do a new one for this cost study, and that our practices haven't changed dramatically since the 2017 time study, and this was an extremely robust and intensive study. We looked at more than 3,000 individuals, and we followed them for 3 to 4 months and captured every minute that was spent in court, officers' time in the field driving to and from their home, time in custody, time at the front desk, talking to support staff, time being staffed with treatment providers, any work that went into that. We have that broken down by officer, by county, by every demographic you can imagine, by every specialty type caseload, how much time for a sex offender case versus a domestic violence versus a drug offense. And we were able to derive what is the actual number of hours being spent per month on each and every one of these individuals, which you can see here, which is just a snapshot of our dashboard that CJC helped us put together, is that on average, we spend about 2.4 hours a month in direct contact with high-risk individuals, 1.5 hours with medium risk, and 0.6 hours with low risk. And that's the sort of breakdown we expected to see, that we're spending more time with our higher risk, more intensive population. And so we take this study, and if we compare it to the 2006 study, and the reason I'm doing that is our current budget is built off of the 2006 time study, but there has been significant change in our practices. In 2006, we were spending less than 2 hours a month with high-risk individuals. We're now at 2.4 hours. Back then, we did very little pre-case management, reach-ins into the institutions. We were averaging 68 hours a month across the state. That's more than 600 officers, and we were only spending about 68 hours in pre-management. With this study, we spent 2,300 hours during that same period of time, reach-ins into the institution, assessments ahead of time, a lot more upfront work to look at who are these individuals, what is the best course and plan, the best treatment plan we can put forward for their supervision. And then we have increased the amount of time across the board that we spend across all populations. And so there's a significant difference, as you can see, in the amount of time and intensity that is being utilized with individuals in the community.
I'm going to have, thank you. I have to ask because if I'm hearing this right, we're spending a whole lot more time on the pre-planning to make sure that things go well. We're spending more time with the high-risk individuals because evidently maybe they aren't following the plans that we spend so much time working on. Are we letting people out too early? Should they stay in, these high-risk offenders? Like, did we get too excited about getting people out that maybe we need to rethink things?
Chair Evans, we would be spending this time regardless of their release date. So whether they're
Wouldn't be able to hurt
releasing
people in the
early or
community,
later.
though.
And a lot of this work did adjust when justice reinvestment was passed. When we started keeping people locally who otherwise would have served time in prison, we intensified our upfront case management. We were asked by the courts to provide more pre-sentence investigative information so they could make those determinations who to send to DOC and who could be reasonably supervised within the community. In direct answer to your question, I would say that it isn't about that length of time. In fact, we've seen the recidivism rate drop and the success of completing supervision increase over the last decade. And so I think this pre-case management intensity has actually wielded the results that we would want to see for this population.
Okay. Still color me skeptical on that, but all right, thank you. Any other questions while we're here? Proceed.
So after completing that time study, we then move into the financial review. So all 36 counties are required to provide the department with the monies that they're putting towards supervision, so their personnel costs, their capital outlay, other indirect costs, what they're paying to provide for the sanctions, the jail beds, not just for those they're housing on behalf of DOC, but those that need a 3-day tune-up in jail or are serving a longer sanction in their local jail, as well as the non-custodial options, electronic monitoring, house arrest, increase intensive supervision and reporting. We then also look at the services. What are we paying for and providing in community corrections, from housing to treatment to peer mentors? And so we capture all of the costs associated with adequately supervising these individuals. So when you take the amount of time we're spending and the amount of cost that the counties are incurring to provide this work, it provides you with a new capitated and daily rate for consideration. So again, if we do nothing different and do not adopt a cost study, the base budget will be $15.09 per person, built upon that 06 time study and the incremental funding and increases that have occurred since then. To reset to the fully loaded rates, the actual cost being incurred would be $18 and roughly 18 cents per person. And I'd love to say, for the cheap cost of $3 a day, we can right-size the community corrections budget, but we know that that's multiplied across approximately 24,000 individuals a day. And that is what drives a substantially large cost study package for consideration as we move forward. But this shows you the breakdown. That upfront intensity work, you can see new cases we're spending substantially more time with. They are the most expensive population. To do the reach-ins, to do the assessments, to develop a plan, we are spending the bulk of our time. We know success is built upon your earliest days on supervision. If we're not working with these individuals intensely right upon release, or upon the court placing an individual on probation, it's more likely we will lose them than be able to keep them engaged and moving forward. And so that is the most expensive cost, and then our high, medium, and low costs broken down from there. When I presented to you in March, I showed you a forecast from October that showed a skyrocketing probation population. That is the lightly shaded dotted line that you see going upwards next biennium to over 17,000 probationers. The darker dotted blue line is the new April forecast. And you will recall from Michael Kennedy's presentation to you a few weeks ago that significant adjustment was made in the anticipated population on supervision. We have not seen the growth during this biennium that was expected, and so he has dramatically adjusted the forecast for this next biennium. And in fact, we won't crest 17,000 for probably another 2 biennium with the current growth within probation. Number of factors with that. So we talked last time about the defense crisis and issues that are occurring that's creating a backlog of cases that otherwise would be coming to probation. We have yet to see the impacts of 4002, and those are certainly hard for us to decipher and to know exactly how many individuals will end up on supervision. And so we see a much more conservative projection for this next biennium. Our post-prison and parole population also wasn't growing as expected, and so you can see a slight reduction there as well for the next biennium. So when you combine those 2 reductions to our 2 primary populations, it brings what the agency had brought forward as a budget previously to a new budget that is approximately $40 million less than what we presented to you in March. The way that breaks down is we take that forecast, and on the left side, you can see our budget build by month. It creates a new base budget of $279 million. When I was here in March, I had presented a base budget of $312 million, so about a $32 million reduction from that initial request. 279 is about 11 million more than the current biennium funding for community corrections, so that would not be very significant, obviously, once divided across 36 counties. And 279, while it matches the current population, will result in some reduction in services from the counties.
Representative?
Thank you, Co-Chair. I'm backing up just a slide, Mr. Stromberg. Thank you so much. Could you, on the probation and the change in the forecast, I know this might be looking into a crystal ball a little bit, but how much is deflection in 4002? You kind of touched on that, but that specific piece of it, how is that impacting those numbers?
Chair Evans, Representative Graber, the issue with 4002 is it's still too early to know the impact. We are starting to see more and more probation cases come online each month. And it's tracking fairly closely so far to CJC's initial assumptions. But even those, CJC would tell you, were built upon pre-COVID conviction rates for small quantity drug possession. And so we just don't know if that's going to hold true, especially with deflection in play. But we are starting to see where folks either have chosen not to go through deflection, have failed the deflection process, or counties that don't have it. We are seeing those individuals now coming onto formal supervision.
Okay, thank you so much. Thank you.
Okay, any other questions while we're stopped? Go ahead.
So that base budget, 279, that is the number that any budget below 279 would trigger the opt-out for counties to return services to the Department of Corrections, similar to what Lynn and Douglas counties chose back in 2004. Anything at 279 or above would require the counties to maintain and continue to provide community corrections operations locally. On the right side, you see the number $340 million at the bottom. That is the fully loaded $18.18. So that's, if 279 is your floor, 340 is your ceiling of what we're saying the actual cost would be. That package was $68 million when I presented to you last time. With the adjustment to the forecast, it dropped it to $60 million as a total package. And so 340 at your top end fully loaded cost study, 279 as your opt-out number based on our current budget build process.
I have a feeling that if we got 340, there'd still be asked for more, but we'll call it a ceiling for now. Go ahead.
My final slide is to give you a brief history of the last 3 cost studies so you have an idea of what the legislative bodies have chosen to do historically. 2006 was the first cost study developed by the department. It was fully adopted at that time. It was a package of about $14 million to right-size the community corrections budget. It was in the 2007 legislative session that the statute was passed then that this cost study should be done every 6 years. In 2012, the department conducted its next cost study, and it was partially funded. In 2013, again, that was the justice reinvestment period of time, and public safety dollars were distributed across a variety of agencies and funding buckets, if you will, and community corrections received a portion of the study that they had asked for at that time, with additional monies obviously put into justice reinvestment initiatives, so the counties did continue to benefit from other public safety dollars. In 2018, we presented the last cost study before this one. It was not adopted during that session. We continued with our base budget. However, in the following biennium, the department worked closely with LFO and developed an exception inflation rate to help keep pace with the personnel costs. A lot of the gap for the cost study is that there is the collective bargaining agreements within the counties. The budget doesn't keep pace with those agreements. There's not a similar sort of salary pot adjustment and focus the way state agencies have the opportunity, and that has created a lot of the gap that we see in the base budget versus the actual costs for the counties. So the use of an exception inflation rate on personnel costs has made a significant difference, and we did see an infusion of money then in the 23 session. So you can see the previous three studies have all been sort of addressed differently, or the outcomes have been dramatically different depending on obviously the revenue cycle, the other public safety investments at the time, and the decisions of both this body and the larger committee. So with that concludes my part of the presentation, and I'm happy to answer any other questions you may have.
I have a question that doesn't have to be answered today. Can get in whenever you can. For the counties that opted out, Lynn County, for example, what's the actual difference right now in outcomes between the counties that opted out and the state is doing, whatever it is we're doing, versus the counties? I'm curious to see.
Chair Evans, it would depend on how we want to define outcomes. I will share with you that over the 20 years that the department has now overseen Lynn and Douglas, their outcomes as far as successful completion of supervision, recidivism rates fall right within the average of all 36 counties. They are no better and no worse than the overall outcomes, but a lot of that has to do with we're still a single system, even though 36 counties operate independently. We abide by the same risk assessments, the same supervision plans, the same approaches. And so you could not tell much of a difference county to county as far as how supervision is conducted.
Except the cost, right? Because you're doing the Lynn County at the state cost, not with the added $3 or whatever it is that the counties need. Is that correct?
Well, Chair Evans, Lynn and Douglas receive their slice of the pie the same as the other counties. The difference, I think, to where you may be going with that is about 10 counties contribute county general fund dollars to supervision. Lynn and Douglas do not receive county general fund at all. But the majority of counties don't either. Most rely solely on the state dollars to provide for supervision. But many of our larger counties contribute additional dollars so that they can run, Jackson County runs a transitional housing component. Washington County has a massive resource center and residential program that could not be funded on the state dollars alone. And so it depends on the local investment as well.
What I'm trying to drive at is, for those counties who quote unquote decide to opt out because it's just too expensive, they don't want to do it. Okay, what is the difference in outcomes? What is the difference to the cost of the state? That's all I want to know. And we can follow up after.
Great.
Other questions? Yes, sir.
So we've heard for, I don't know, 3 or 4 sessions now that community corrections is underfunded or has been underfunded, and the counties are subsidizing. So what is, right now, as I understand it, it's at 1509, is that where we're at right now?
Correct.
Okay, and so this would increase it to 1818 if it was the 340 million. What was the governor's recommended budget?
Chair Evans, Representative Lewis, the governor had incorporated $20 million of the cost study into the budget for a total budget of $332 million.
Okay, follow up?
But that was a different number, yeah.
Yeah, so for another $8 million, we could get at the 340 that we need to be at, correct?
That is correct.
Okay, thank you.
But that number that the governor sent in was on a different forecast.
Chair Evans, that's correct. The governor's budget was built off of the October forecast.
But in real numbers, it's close to what we need. We got lucky, maybe. Okay. Other questions? All right, thank you very much.
Thank you.
Proceed to the next section, sir.
Chair Evans, thank you, and I'll invite Assistant Director Thom Martin to come up and lead us through a presentation on the placement of the Oregon State Penitentiary, and then we'll take questions on that, and then he'll also lead us through the development of a medical facility for our aging population.
Sounds good.
Good morning, co-chairs Broadman and Evans and members of the committee. For the record, my name is Thom Martin, Assistant Director for the Administrative Services Division of the Oregon Department of Corrections. We're here to speak to the needed replacement of the Oregon State Penitentiary and the project plans for the 25-27 biennium. Later, we'll be presenting on how we provide medical support to our aging adults in custody population and the needs for a medical facility. By way of background, I came to the Oregon Department of Corrections 6 years ago. In my prior career, I worked for over 20 years with a Fortune 100 company, where my focus was on large-scale project management. I mention this only because it helps me to understand what it takes to execute a multi-year building project with this magnitude. With your support, I'm confident that our team can execute what I will be describing today on time and within budget. Many of the main structures on the OSP campus are over 100 years of age and were not designed for the populations we serve today. The programs designed for rehabilitation, or the programs were designed for rehabilitation. Our 2020 facilities strategic plan showed that the institution would need an addition of over 203,000 square foot of housing to meet the current American Corrections space standards. We're also currently taxed with the current need of behavioral health treatment space, our aged population needs, and overall deterioration of the building and infrastructure at OSP. I'm sure you know our prisons are akin to small cities. OSP has a capacity to house over 2,000 individuals who live in the city 24 hours a day. They eat here, sleep here, shower, work, recreate, rehabilitate, and are medically treated here. Our staff also spend a good portion of their lives within these walls. And OSP, at over 100 years of service, is well beyond its useful life and doesn't support the level of care needed to support our incarcerated individuals. Estimated investments to come into ADA compliance, improved functionality, and maintenance of aging buildings at OSP exceeds $200 million and will continue to grow exponentially. OSP's current deferred maintenance and seismic retrofit needs alone are in excess of $110 million. And to bring the HVAC needs to current standards is estimated to be just over $25 million. I'll briefly cover just some of the challenges we are faced with today at OSP and walk through our plans for the replacement of the current construction of a modern prison in the coming slides. We'll present our request for the healthcare facility and a simultaneous project in a coming presentation. Our physical plant teams are currently doing all they can just to keep up with the emergent issues, some of which I'll cover here, and have limited time, and they have limited time to defer to maintenance and upkeep items. The picture here is of a fire sprinkler system in one of our buildings that upon testing, the flow was not there. As we looked at it, these pipes were just filled with sediment. The entire system in this building had to be replaced. This is of our shower facility located in the basement of one of our housing blocks. As you can see from this picture, the current space is continually damp, severely outdated, and does not meet current standards. Other concerns throughout the institution include constant noise due to outdated equipment. We have 100-year-old cable and mechanically operated door mechanisms. Inadequate HVAC creating cooling issues. For instance, tier 4s and 5 have registered temperatures of 110 degrees in the summer, and the floors can absolutely freeze in the winter times. Outdated walls of single pane windows, no functional day room or seating on several units, and there are areas that lack fire suppression systems as they were built before they were required. Pictures for the next few slides represent just a very few items we have encountered in the recent months at OSP. This is a boiler line failure. Boiler failures mean there's no or limited hot water for our AICs. Temporary boiler units brought into continuous service are nearing $100,000 a month to have in place while repairs are being made. This photo is of a building on property just a month and a half ago, where staff work daily. As you can see, there's 6 inches of standing water covering the HVAC unit. And on the other side of this room is the water heater and electrical room, also engulfed with water. This was created by a broken drain pipe near the building. And these are very real concerns and continue to tax the already thin resources in the physical plant just to keep the prison functioning. This was a main sewer and runoff line break coming out of one of our housing units. These sewer-related pipe issues are becoming a very common issue. This pipe was broken very near the building, and they run under the foundations of the building, of the housing blocks. When they break, there's a very real scenario where we'll have to relocate over 300 AICs to other sites, both costly, and there's a lack of appropriate custody-level housing elsewhere to house them. As you might guess, these unplanned and emergent repairs are for the most part not on the deferred maintenance list and are in excess of the over $110 million we know the institution needs to come in alignment with maintenance standards.
We have a question.
I'm just curious. Thank you, Co-Chair. That looks like PVC piping.
This was the repair.
That's the repair. Okay, I was
Oops,
like, thank you. Wanted to make sure. That doesn't look like it's 100 years old.
The director asked me the same question on that slide. I should
Okay.
have put a different one, maybe.
No, that's all right. Thank you.
You
Thanks
bet.
for the clarification.
These unplanned disruptions created by 100-year plus old infrastructure, along with the known deferred maintenance costs, the ADA compliance costs, replacement space needs of our current infirmary and our aging population needs, and lack of appropriate programming space are just a few of the reasons why we're requesting the funding to replace OSP. OSP currently houses AICs that use walkers and wheelchairs, as we've covered in previous presentations. These AICs need, these AICs need Tier 1 housing, and that housing is limited at OSP. For instance, there are currently 247 AICs at OSP who either have are stair restrictive or in need of a bottom bunk. There are also cases where AICs that could be housed here in Salem but cannot be because of limited Tier 1 housing available. This means that some AICs may not be close to their families or services that may benefit them. The geriatric unit on E block pictured above has multiple challenges, and some of which include inadequate openings for wheelchairs and walkers, ADA cell requirements, and ADA geriatric AICs are limited to low-tier cells, and OSP is up to 5 tiers high, with no elevator to access upper tiers. Critical resources such as counselors, ADA coordinators, chapel, the law library, and the barber shop, and more are located on the 2nd, 3rd, and 4th floors of the main institution. AICs and staff with disabilities have a very hard time or just simply cannot access these resources, as there is no elevator to service these floors. The lack of access to these areas impede the ability of many to utilize these services. In addition to some of the things I've mentioned previously, there are just several other concerns, like staff responding to critical incidents on the upper levels must navigate stairs to provide aid and support, difficulty accessing legal phones, and much like the rest of the institution, again, temperatures can reach 110 degrees in the upper cells and upper rooms of these counseling areas. Our infirmary. So the infirmary at the Oregon State Penitentiary is severely outdated. It's undersized for the demand and needs significant repair and updating. The facility's infrastructure suffers from numerous issues, including leaky roofs, inadequate heating and cooling systems that hamper the provision of effective health care. The cramped and deteriorating space is insufficient to meet the needs of the growing geriatric AIC population, resulting in overcrowded conditions that further strain the already limited resources. These conditions compromise the quality of care that we are able to provide and pose serious health risks to both AICs and staff. It is also worth noting that the infirmary is located on the 3rd floor with a single decades-old elevator as the primary source of egress. When the elevator goes offline, stairs are the only option and can be difficult to navigate for people with disabilities or injuries. One note that I'll add is that institutions will still need a clinic and infirmary regardless of the addition of the proposed medical facility that we'll be discussing in our next presentation. Special Management Housing Unit at OSP is not conducive to the rehabilitation of AICs. The current design of this unit makes it very difficult to provide effective care and supervision of this population. There's a lack of windows in the cells. The cell space is very limited, and the punch plates on the cell fronts shown in this photo further enhance isolation. These design restrictions and small cell sizes contribute to feelings of being closed in and stuck for the AICs. The door and cell controls are also severely outdated, and our staff have poor visibility within the housing units, particularly in the corner cells, intensifying safety and supervision issues. When our AICs have recreation time out of cell, their outdoor recreation areas are small with limited light and airflow as well. This next picture is a picture of actually one of the cells inside on the special housing unit. These housing units lack natural light, negatively impacting the AIC's time of day orientation. These units also suffer from poor airflow, and this adversely affects the mood, health, and overall wellness of both AICs and our staff working in those areas. This environment creates confusion, isolation, self-directed violence, increased symptoms of medical and mental health issues, and violence and agitation towards others, including staff.
Just, who would be in the special housing?
It can, Chair Evans, it could be a variety of people. In the special housing unit, you might have behavioral health issues, you might have disciplinary issues, you might have a vulnerable population that needs to be isolated from other adults in custody.
Proceed.
All right. This slide represents the offices of our behavioral health services staff and their clients. Many of our BHS offices and treatment spaces are wedged into already tight floor plans and are not conducive to providing the level of care we would like to provide for our AICs, nor the appropriate working conditions we would like to provide for our staff. In our 2020 facilities strategic plan conducted by the DLR consulting firm, called for an additional 50,000 square feet of programming space needed. In our path to improvement, the upcoming slides will walk through the next steps and the approach we plan to take to address the issues we've covered with our current prison. In 2020, DOC, as mentioned previously, worked with the DLR group to develop a facility strategic plan. And we updated this plan in 2023 to garner a better understanding of the current state of deferred maintenance costs. As mentioned previously, the initial 2020 plan surmised that to meet the American Corrections space standards, we would need an additional 203,000 square foot of housing space, along with as much as 50,000 square feet of additional programming space at OSP.
And is that a federal requirement, or is that as we've been dealing in this building for the last year on another issue, public defense, an aspirational unicorn version?
Rep. Evans, it's a aspirational piece, however, it is the standards. We are not bound to that.
Well, standards generally imply a lot of people are following them, not the standard we want to get to. So, which is it?
I would say it's a standard we want to get to.
Most states haven't met it.
I'd have to research that.
That'd be a
Rep.
good thing
Evans.
to do.
You bet, we'll
Go
get
ahead.
that to you. We currently have available property at OSCI and a ready-to-build property at Junction City that is sited for a prison. The feasibility study will determine if the land at either of these locations will be suitable for a new institution. And to better understand the needs, a basic conceptual design will be commissioned for layout to fit the current needs of our population. The feasibility study will encompass items like environmental assessments, assumed utility loads, archaeological reviews, community impact studies, and zoning planning on 2 properties, and will top $750,000 for each site. The 2 sites that we'll initially study are OSCI and OSP for the OSP replacement, and SCI for the healthcare facility we'll be speaking to in the next presentation.
We have a question.
Thank you, Co-Chair, and thank you all for this presentation. When I think about the role of this committee, I've often said, right, we have 2 main goals. One is ensuring public safety. The other is being good stewards of taxpayer resources. Not having been in this role, but thinking through recent legislative history, it strikes me that moments where there were big potential DOC expenses coming up have been moments when we've found other legislative solutions. Justice reinvestment is one example. The need for a second women's prison is a second example where, for justice reinvestment, for every $1 we spend, we've saved $3 for taxpayer money, and at the same time have seen no impact on public safety, or at least no detrimental impact on public safety. In thinking through $4.5 million just to start designing what this OSP replacement would look like, and then that amount will be much, much, much larger, I'm sure. What legislative solutions or ideas has DOC thought about or considered kind of as an alternative to this?
Rep. Evans and, Chair Evans and Representative Choatson. I think that's a great question because justice reinvestment did alter the course of prison construction in Oregon. Junction City was due to come online, and the governor at the time, working with the legislature, designed justice reinvestment to push out the facility that was to be built in Junction City. We are looking at the same forecasting and seeing that our prison population is fairly stable and flat for the next decade. This isn't about adding capacity to the system. It's more about replacing an institution that is outdated and as Assistant Director Martin said, it's going to cost us hundreds of millions of dollars to retrofit or rebuild. So we're trying to be planning for the future and thoughtful in how do we replace this in a planned approach as opposed to a catastrophic closure of an institution that doesn't meet ADA requirements, doesn't meet the expectations of the adults in custody in terms of rehabilitation and for our staff as well. So it's not about the capacity of the system, it's more about replacing an institution that is at the end of life cycle.
Follow-up.
Thank you so much, Co-Chair, and thank you for that answer. I guess one specific idea I just would love to hear your all's thoughts on. Currently under law, right, and this is something we deal with under existing law, some of the folks within DOC are eligible for earned time and good time. Some of the folks within DOC are not eligible for earned time and good time. When I talk to the public servants who work within DOC facilities, I frequently hear that that's a really powerful tool that incentivizes good behavior. When I used to teach economics, people respond to incentives was like a day one thing that we would talk about. So I've heard, I think, from many of the DOC employees that good time and earned time being available to more people would increase safety within our prison walls. I guess I'm curious whether you agree with that, first of all, that would make our prisons safer internally. And then secondly, what impact would that have, and maybe this is something that needs to be followed up on, but on the kind of capacity needs around that?
Yeah, Chair Evans and Representative Choatson. I think that incentivizing good behavior through an earned time or the short-term transitional leave have worked well for us. Currently, I believe the short-term transitional leave is 120 days. That seems to be the maximum where we see the benefit of those incentives. And it also, we have our alternative incarceration program that is very intensive for folks that have substance use disorder issues, and the treatment program there incentivizes good behavior as well. So we want those two programs to work well together, and they do currently. If we were to increase that that incentivized time, we may not see the benefit. And if there was a release in the population, it would only be a short term. And then that capacity would come back as all of the people that were eligible for leave would be released. And then you would see just the other end of the system filling it back up. I think the population is going to be stable for the next decade or so, unless, of course, there are legislative changes, alternative sentencing, or something upstream that keeps people out of incarceration.
One last quick follow-up.
Okay.
Thank you. I guess just to clarify, my question was less so about expanding the time for short-term trans leave, but about expanding the eligibility of who would be eligible for a program like that, or expanding the eligibility of who's eligible for good time and earned time, and how that would affect capacity needs going forward.
Yeah, Chair Evans and Representative Choatson, I think those are legislative changes that would need to be in place. Currently, everyone that's eligible for those programs receives that opportunity.
Thank you. Thank you.
So, a couple things as a follow-on to the Representative's initial question. We've been talking about this. I want to make sure it's included in the conversations of the study before people start spending millions of dollars and cutting down forests to put reports together. Mm-hmm. If the population is going to be stable, I can get that. That doesn't necessarily mean that as people become older, their needs are constant. So are we also looking at not just replacing some of the Oregon State Penitentiary, but also looking at other spaces and other places we need to move people so that healthcare costs and other factors are into it? Because what I don't want to see is, and again, it wouldn't be your fault because you're relatively new, but you came in and we need to have a program to, by golly, replace an institution, so we're going to do that without considering the other institutions that are in the mix and if we want to move the populations. So please assure me that the certified smart people that we're going to pay a whole lot of money to are going to pay attention to that.
Chair Evans, that is correct. And as we look at the feasibility, and we'll get into the medical care, healthcare facility that includes that geriatric population, we want to look at partnerships with other private or public agencies and entities that might be able to provide some of those services at a lower cost than the Department of Corrections can, or could provide it in a more effective fashion.
And the other component, which is going to be not terribly popular to say, but it is Oregon law. I don't really care so much about the aspirational hopes, and I don't care if people are in 110 degrees because Iraq was 123, so I'm really not terribly concerned about that.
I was there.
But in the statute, we still actually have a death penalty. And we don't have a place for the law to actually be executed. So as they're putting together a plan, please make sure it's adhering to existing state law, not temporary actions. Thank you. Proceed.
You go, Chair. The funding we're requesting for the OSP replacement for the 25-27 biennium will cover the feasibility covered in a previous slide and create a conceptual design for the project based on the work in 2020 by the DLR, on development of the facility strategic plan. The procurement and build concept we plan to utilize is the CMGC, or Construction Manager Contractor, or General Contractor Solicitation Model. This will allow for this allows for early collaboration, cost control, risk mitigation, and time savings. The build design timeline will be somewhat progressive and extend into the 31-33. Actual end of construction time is going to be dependent on the actual plan and contractors, obviously. The 27-29 biennium will focus more on design document completion to the GMP, or guaranteed maximum price level, and construction agreement, with design, commissioning, and consultant oversight extending through to completion.
That's a prison?
This is actually a modern prison. Not saying
like a
that that's
church.
what ours will look like, but it is a representation of a modern prison in Norway.
Of course.
Yeah.
Go ahead.
Do we want to show this presentation?
Chair Evans, we were going to show a video, but in the interest of time, we'll moved past that. It's from KGW, came into the Oregon State Penitentiary and did an investigative report and highlighting some of the challenges we have there. But Assistant Director Martin has covered those, so we'll move forward.
Good call.
Okay. I don't envy your position with the many competing financial asks from DOC and other public safety agencies. My goal today is to share with you clearly that we have an uncompliant, dilapidated, and rapidly disintegrating facility that negatively impacts our ability to achieve our mission. While there are real costs involved with the new construction, I believe that this will save the state millions of dollars in avoidance of short-term emergency repairs and possible lawsuit-related costs. In short, it's a smart investment. And with that, I'd like to conclude this presentation and open it up for any questions. All right. We will jump into the centralized healthcare facility. Do we need to open this one back up again, or we're good? Okay.
Keep going.
Okay. We're here to speak to the current needs and benefits of building a medical facility that will allow us to provide clinical, acute, and long-term care for AICs in our custody, and to discuss what we plan to accomplish with this project this biennium. This facility will also house our main pharmacy and our transport unit, and we'll speak to that throughout the remainder of the presentation. Co-loading the transport unit on the medical campus will allow for a more centralized, cohesive approach to medical trips, and our current transportation unit offices and bus parking are not optimal for proper care of our vehicles, nor to accommodate all the transport staff team. The medical care facilities within our institutions here in the Valley, for the most part, are severely outdated, undersized for the demand, and in need of significant repair and updating. The cramped and deteriorating spaces are insufficient to meet the needs of the growing geriatric population, resulting in overcrowded conditions that further strain the already limited resources. These conditions not only compromise the quality of care provided, but also pose serious health risks to both AICs and medical staff, highlighting an urgent need for the requested healthcare facility. Graph on this slide shows that over the past decade, the 55-plus population has grown by 15%, and is expected to continue on that path. As you'd expect from an aging population, the healthcare associated with these AICs also becomes more difficult to manage. The new facilities will allow for dementia care, end-of-life, hospice care, along with other care traditionally requiring off-site medical visits. For adults in custody on hospice, those enduring long-term stays in the infirmary, or that need specialized assistance, our current institutions are not equipped to provide environments that offer appropriate space or care for these patients. Creating a centralized healthcare facility is one step in providing effective, efficient specialist care to AICs. Developing a campus that allows us to serve acute populations by providing modern medical services and geriatric care, as well as housing a centralized pharmacy and a transport unit, would be effective use of resources. Our pharmacy here in...
Go ahead.
Thank you so much, Co-Chair. Going back to the previous slide real quick, all of this care feels like on the more expensive end of the care that DOC needs to provide. Are we able to pull down any Medicare or Medicaid dollars for folks that are in DOC facilities or not?
Chair Evans, Representative Choatson, currently we are not, unless someone is released from custody, a custody environment. We are working on the Medicaid waiver proposal, which would allow us to tap into Medicaid funding about 90 days from a person's release from custody, but not for the long-term care of someone who is aging out and potentially going to die in our custody.
Okay. Quick follow-up on that.
Okay, and then Representative Daisy.
No, go for it. You might ask my question.
Great. I guess I was wondering if it seems to me like folks who are on hospice care, memory care, geriatric care, long-term stays are least likely to recidivate, least likely to reoffend if released. Obviously, we can get data on that. I don't know if you all already have that data. Again, this is where policy and budget intersect very closely. But I guess, is it correct that if they were released but in some sort of secure residential facility in their communities, that we would be able to use some of those federal resources to pay for the health care instead of just using state resources?
Chair Evans and Representative Choatson, I believe that is correct. If we were to release people from custody to a secure facility, but that would require either legislative changes or the governor making some decisions about commutation or early release from custody. It's not within our control to release people to those facilities.
Understood. Thank you.
Thank you, Chair. Just a brief follow-up on that. So instituting more procedural compassionate release from a legislative side, what percentage of this population can you just roughly estimate might be up for that?
Chair Evans and Representative Graber, I'll have to get back with the exact number. We can pull that up. How many people are either in, just so for clarification, in some sort of memory care where they would be potentially not able to leave custody on their own, or in hospice care? That would be the population you would be interested in.
Yes, please. The merging of the low recidivism possibility with folks that are at end of life stage.
Thank you.
And memory. Thank you.
So in previous conversations on that topic, one of the factors has also been the victim's concerns. So
Absolutely.
I think it's probably appropriate that that's a legislative choice as opposed to a administrative choice right now, because I think that there's a lot of factors that have to be weighed in that. All right, other questions?
One more.
Of course.
Thank you, Co-Chair. What's, and just in terms of the healthcare costs, what's the high end of what we're paying for an individual AIC's healthcare per day or per month or whatever, however you measure it?
Chair Evans and Representative Choatson, I'll have to get that number from our healthcare administrator.
Anything else?
Nope. Okay.
Senators, any questions? No? Okay, proceed.
Right. So our pharmacy here in Salem is a leased facility that is, I need to flip that, is a leased facility that's aged and not physically suited for modern pharmacy functionality. Additionally, the proximity of the pharmacy to the medical facility is important to the administration of some drugs, such as oncology medicines. The ability to produce and administer these types of medicines in-house would save nearly 52% on our current spend just on oncology meds. For instance, between April of 2024 and March of 2025, we had 377 oncology-related trips into the community. Of those 377 trips, there were 120 individual AICs at a cost of just over $5 million, $5.09 million. Each of these trips to a hospital or outside medical facility for the AIC also requires 2 staff, or 2 officers to accompany the AIC. These costs are not included in the expenses I just covered. With the new pharmacy, we would also be able to include a compounding area to create medicines that we currently have to purchase. Our current pharmacy locations and structures do not allow for the options due to building requirements that cannot be met in the current locations. We'll also have access to critical care medicines 24 hours a day with an on-site pharmacy that is not possible with our current process, and will allow for significantly better resources to care for our acute patients. And much like our previous slide, our path to improvement, we conducted a facility strategic plan exercise in 2020 that showed the need for a medical care facility. And in that plan, conducted and created by the DLR group, the placement for the facility was at the SCI property. As in that plan, SCI was to be the housing unit for the AIC support crew for the new medical care facility. Part of the feasibility portion of this project will focus on the right location for the construction, including available medical resources and proximity to care. It is possible that the study will determine a more suitable location for the build due to proximity and available medical resources or medical resource capacity. We'll utilize the information from the DLR report to assist in the conceptual design for this portion of the project, and that'll significantly reduce the costs for that piece.
And if I could highlight that this proposal is looking at a campus-based model where we have OSCI and the San Am facility, which are near DPSST, if you're familiar with that area. And then we have several hundred acres of additional property adjacent to those two facilities. So we would look at replacing the Oregon State Penitentiary and building a healthcare facility in that location. And the proximity to the healthcare facility to San Am allows us to use adults in custody who are on minimum custody status and planning to release back into the community. We can train them to be part of that peer mentor healthcare provider team that looks after hospice care and aging patients. And then those folks would develop certifications that would allow them to have those types of jobs when they're released.
All right. In addition to the conceptual design work, the funding we're requesting for the medical facility for the 25-27 biennium will cover the initial feasibility. The design build timeline will be, again, somewhat progressive. It'll match with the OSP build. Both the medical facility and the OSP replacement are looking at adjacent parcels, like the director just said, here in Salem. It would make sense to co-develop both projects as they could be worked on simultaneously at these locations, potentially avoiding duplicate work and saving some costs there. The bid build concept we plan to utilize for the project, again, is the construction manager contractor or general contractor solicitation model. And this allows for early collaboration, like mentioned previously, risk mitigation and time savings. Combining the required work for the OSP healthcare facilities and will reduce costs in planning and design, construction, and allow for coordinated construction timelines to drive efficiencies and adherence to expected deliverables. This isn't the representation that we actually got from DLR, but it is a kind of a modern healthcare institution. And with that, I'd like to conclude the presentation. I thank you for your time today and open it up for any questions you may have for us.
I don't think we have any questions. Thank you very much for the presentations.
Thank you,
Much to
Co-Chairs.
digest. We'll follow up on some of the specifics.
I got one.
Okay.
Co-chair. Sorry I missed that. I had to testify. And if you covered this, I'll just circle back offline. Did you discuss funding for actual care in how we need to design the facility to make sure that we are coming up with new funding streams to improve care?
Chair Evans and Co-Chair Broadman, yes, Medicaid, the Medicaid waiver may pay for some care costs if we were to have folks that were within 90 days of release from custody. For longer-term care, we would be willing to look at, as part of this feasibility, partnership with a healthcare provider that may allow people to be in a secure facility but not in a traditional custody environment.
Thank you.
Or a hybrid of that model.
Thank you.
Yep. Good question. Other things? All right. We're going to close the informational hearing. Anything else for the good of the order today?
One last comment, Co-Chair.
Yes, sir.
Thank you. I appreciate it. I mean, I really do appreciate the presentation and the information given the existing laws and policy we have. And also, I don't think I would be doing my job as a legislator if I didn't point out that I think there's a real opportunity here. The nonprofit FAM gives Oregon an F in terms of medical and compassionate release policy. So whether we're looking at the medical release laws that we have in place or whether we're looking at eligibility for earned time and good time, I think there's an opportunity to improve on public safety, to save a lot of taxpayer money, and then to reinvest that money, to your exact point, Co-Chair Evans, into things like victim services and prevention in the community. And so given the role of this community, I just think that both in terms of looking at earned time and medical release, those are two real opportunities to save and reinvest that money and improve public safety. So I'll put that out there, and I appreciate the time.
Anybody else? All right, Steve?
Thank you, Mr. Co-Chair. Tomorrow you'll have the Board of Parole and Post-Prison Supervision here to provide invited testimony. And a reminder, tomorrow will be the last day for a public safety sub meeting this week. Thank you.
All right. We're adjourned. Whoever got the hamburger?